Hi, my name is Kim Bland. I'm a nurse practitioner, Methodist Palliative Medicine. Today I'm going to share with you how nutrition plays a role in what we talk about with our patients and how we look at our patients. So the objectives for today, we're going to talk about palliative care, which patients are appropriate and why we recommend palliative care, and how is it different than hospice care, because often it gets mixed up between the two of them and what people think we do. We're going to look at nutrition and hydration based on the patient, their needs, their goals, and relation to palliative care discussions. And then we'll talk about artificial nutrition, medication supplements that may help with appetite stimulation, and then how does advanced care planning fit into this? So as a basis for our discussion today, I want to begin by saying palliative care is an approach that we use to help improve quality of life for patients, help with their symptoms or burdens, and those can be numerous different types. So Dame Cicely Saunders was one of the founders of palliative medicine, and she believed in total pain. And what that includes is physical pain, such as symptoms, pain, nausea can be distressing and symptomatic, could be psychological. So if they have emotional distress, existential distress, feeling poorly about themselves, feeling like they're a burden on their family. It could also be social, in that if they're ill, they may not feel like they're a part of the group anymore. They may feel like they're set outside of the normal family gatherings. How they're treated by the medical team. Are they provided with dignity with what they're going through? Are they treated as a human with respect? And then spiritually, so how do they transition with what they're going through, and how do they make sense of all this and the whole bigger picture of what their life meaning is? All those things play a factor into how patients do, part of our discussions, and how it comes across with how we can best help them meet their goals. All these things play a part into how a patient does. With palliative care, we see people that have a life-threatening, could be a life-limiting illness, people that come to the hospital frequently, those that are just the highest risk for having something not go well. And the palliative care approach can be done at any point in someone's life. So if somebody's got serious illness, we're not sure how it's going to come out. If they've had an acute illness, they have trouble coping, they're having lots of symptoms that are weighing heavily on their life. They need help with talking discussions of how much care do I do, what's the right amount of care, helping with getting their family all together and on board with whatever they want to do. Palliative care is anytime a patient wants more support and help as they're going through a difficult time. And so both palliative and hospice focus on how do we make symptoms better? How do we help them mentally, spiritually, coping with what they're going through? How do we help them have the best quality life possible? Whole team is involved. So we don't do this alone. We as nurse practitioners, physicians, we have nurses that are in our department. We work with nurses, inpatient, outpatient, social workers, care managers, dietitians, you name it. Whoever we can pull in to help somebody, all part of our team, chaplains, pharmacists. The difference between palliative care and hospice is that, again, palliative care can be seen patients any point of an illness or injury, things that we can help with to make their life better at that time. With hospice, it's really looking at someone who's nearing end of life, and do you have what we estimate 6 months left to live or not? Again, we're horrible at predicting prognosis. Clinicians tend to over predict by about 6 to 7 times what the people might actually live. And so it's a guesstimate, our best guess. Are they nearing end of life? Are they showing signs that things aren't going as well? And so if the focus is on quality, light, and comfort and not on treatment, then that's where hospice comes in. And the palliative care, we work alongside people that are getting curative in treatment or palliative treatment, like chemotherapy, radiation. I follow a number of people on the outpatient side that aren't getting treatment, but they're not quite ready for hospice. So I can be that transition period to help with their symptom management and discussions until they're ready for hospice. The difference is on the outpatient palliative care, our clinic is open Monday through Friday, 8 to 4, but we don't have weekends, we don't have holidays, nighttime, that sort of thing. And so if somebody is not getting treatment and they really want to focus on quality life, we recommend they at least meet with a hospice team to get more information, because that hospice team then is available for 24/7. We don't know, again, how long prognosis is, but if they're not getting cancer treatment, we know that cancer is likely to grow. And so they could be on hospice until, they're at end of life. Even if they start very early on, that prognosis, that diagnosis is not going to change. We know cancer grows. It's not going to get better without treatment. So if they have advanced stage or metastatic disease and elect no treatment, then hospice information and consideration for early enrollment will really give them that 24/7 care that they can access, whereas palliative care doesn't. So sometimes people think that, palliative is just a way to get people into hospice, but we really want to help people at any point that they can. And then when hospice is appropriate, we have those discussions and help them. Now, why do we encourage palliative care in the hospital setting? In nursing homes, it's used. People can see palliative care in their homes. And the other piece of it is not only helping the patients and families, but how does it help the healthcare system? So when palliative care is on board, we really differentiate and delineate what their goals are. How much care is the right amount of care? Often we talk about code status. And so if somebody says, gosh, I don't really want to go to the ICU, I don't want to have chest compressions, all of those things help to save distress on the patient, also helps them improve their quality of life, to know that we're their advocate, and we're going to help that whole team understand how much care they want and not do more than they want. And so you can see the quality of life improves, the symptom burden goes down when we address symptoms, and even their mental existential distress goes down when they feel like somebody really hears me and wants to help with me. So of those patients that are seen by palliative care, research has shown that the vast majority of them say, gosh, some part of that was helpful. So quality of life for the patient and the family. The other piece, as we talked about, if they elect not to do some treatments, or we can get their decisions made a bit faster, we can get their symptoms under control quicker, it helps with avoiding extra cost. And so across the spectrum of healthcare, from inpatient to home-based, you can see there's fewer admissions, there's fewer costs, fewer ED visits, just really making sure we understand what that patient wants and how do we best address their needs to get them out of the hospital setting and not do the things that they don't really want to have done. The best model for palliative care is in collaboration with current treatment. So whether that's curative, as this is on here, it could be palliative treatment, but when they're still getting treatment, if palliative care is on board very early on, even if they have a diagnosis of advanced or unresectable or metastatic disease, get us on board early so we can start having those conversations. Much easier for us to manage symptoms if we can start early and get medications on board, get adjunct therapies on board, rather than waiting until they come in and they're so uncomfortable that, in our clinic, they have to lie on the couch because they're just miserable, or they have an emesis bag with them all the time. We want to help long before that. And so when someone's first diagnosed, the focus is really going to be on what do I need to do to get that treatment. And so this curative care, or the palliative care, is really a focus. But our service as palliative care, we can help early on. How do we help with education? How do we help with making sure they have their questions answered? And then really symptom management again. And so palliative care follows along as they're getting their treatment. Sometimes they have more needs, so it's more of an up and down rather than a straight line. But what we know is at some point that treatment that they're getting for that diagnosis may not work as well or may stop working. And so at that point, that's where palliative care focus, presence increases. And then maybe they're getting a little bit less of that curative or palliative, meaning make them feel better, treatment. And so at some point, palliative care may very well be the primary provider, and then the others take a back seat because there's not much more they can offer. And so we just help them with making sure that symptoms are well controlled. And then when it gets to the point where they're at the end of what we can do, then that's where we flip them over to the hospice team. And the hospice team is important not only for that 24/7 care, but that triangle on the end for bereavement. They'll help families with bereavement for 13 months after someone has passed away. So really introducing us so that they see us as part of the team, at the very beginning rather than, oh gosh, now you're so bad, you need palliative care. And so works much better. I see a lot of people on the outpatient setting that I see early on. We talk about code status, we talk about how much care, we talk about advanced care planning. They may not have symptoms, but I say, gosh, you know what, you're going to be starting treatment, you might have more symptoms. If you need something we can help with, call. And so maybe 3 months down the road, when they're in the middle of that darn treatment, they're like, yeah, I could use some help. If I've had an initial meeting, it's much easier to just pick up and take off with symptom management rather than having to wait to schedule a new visit and trying to, again, get ahead of the symptoms. So earlier that palliative care can be involved, the better. And so it's appropriate for people that have anything that's life-threatening, life-limiting, or potentially. So there's a lot of cancers that we see. Maybe the patient's an earlier stage, but they have such other poor health that they can't get fully curative treatment. Maybe they don't want as heavy as treatment as they can. So we can help with some of those discussions and symptom management. Heart disease, lung disease, kidney disease, liver disease like cirrhosis or hepatitis. We have discussions about how much care, what do we do? HIV and AIDS, there's a whole complement of things that go along with that diagnosis that maybe we can help pull in resources. Dementia, education is so big with dementia, and knowing for that family what to expect so that they're not surprised when their loved one starts falling or not able to eat like they used to. Talking about not doing feeding tubes for those patients because they're not appropriate. If somebody has a stroke, think how life-changing that is. Multiple sclerosis or other neurologic diseases that take away their ability to not only eat, but stand and breathe sometimes. We have to talk about how much respiratory support. Would you accept a trach? Would you accept living on a ventilator? So starting those conversations early when they're not so frightening. And then if we see people come in the hospital frequently, we will often be consulted on the inpatient side to say, what can we do? Are we doing the right care? Or maybe they need more care at home, or maybe they're hospice appropriate. So how can we help them? If they come in because of their symptoms, maybe we can have more frequent phone calls on the outpatient side to kind of break that cycle so they don't come in as often. So anybody palliative care, life-limiting, life-threatening, anybody who's high risk for coming back to the hospital, they don't have a lot of support. If we in the hospital system see somebody and we're not sure, do they have the ability to make their own decisions? Caregivers can't manage somebody at home anymore. Just frail, lots of comorbids such that giving medical treatment can be hard. If they don't have any treatment options, or if the patient is kind of limited what their options are. Those are just a number of ways we can help patients, inpatient, outpatient, both. And so when we look at nutrition, that plays such a vital part in how our patients do. And nutrition is such a basic function for everybody. I mean, socially, go out to eat. It's just a part of what life is. And so we want to make sure with everything that people can be diagnosed with, how does that affect how they can eat, how they can swallow, their taste, that sort of a thing. So proper nutrition is so important to keep their albumin, their protein levels up, to keep their muscles strong. And how do we make sure that they have that throughout their treatment? So if they have good nutrition, they're getting proper fluids, they tend to do better through treatment. Helps manage their symptoms so that they can, continue to enjoy those outings with their family. But we want to get to know that patient, that family, make sure they understand what their diagnosis is, what might happen if they select a treatment, how maybe that would alter their lifestyle, their nutrition. What are their values? What do they want to do? What's their priority? Focus on comfort and pleasure. If they don't want to have a lot of care, we can talk about what that looks like. The challenging part with cancer treatment is if somebody's getting cancer treatment and they're not able to eat and drink properly, then they're high risk for becoming cachetic. And, if somebody loses 5 or 10% of their body weight in 3 months, that's actually a hospice criteria. Our goal is to intervene so they don't get to the actual cachexia, because that's much harder to turn around than just losing weight. But all those things have to be a part of our discussions with patients. And so if we look at how do we assess them, what do we talk about? We look at the patient as a whole. Do they have aspiration risks? Are they swallowing wrong? Do they have the ability to hold their utensils, or do they have such bad neuropathy? What other symptoms do they have? Do they have nausea? Do they have bowel obstructions or constipation that affects how much they're able to eat and drink? We ask our dietitian colleagues to come in and recommend and do their assessment. You know, do they have regular bowel movements? Do they have issues like, Roux-en-Y or gastric sleeves that affect how much they can eat and digest? The other piece we look at, are they early on and they have a long prognosis, or are they much, much farther on in their course and they just have a limited prognosis? That may change what the patient wants to do. If they value eating and drinking, we might allow that, even if it's more of a risk for them in the short term. So we have to look at all those things to say, gosh, what does this whole picture look like when we talk to somebody about nutrition? We know that proper nutrition is really important to how someone does. And so if you don't have good nutrition, you can have more side effects. You can have more falls. You can have more anemia, worse quality of life. So many things that if we don't have good nutrition, balanced nutrition, good protein intake, that patients aren't going to do as well. We know that. That's well documented in the research. We take head and neck cancer patients as an example. I think this is a great option to look at when we look at nutrition, because so many things with head and neck cancers affect the ability to eat and drink. Head and neck cancer is the sixth most widespread malignancy in the world. The people that have it go through often very daunting treatment to get a chance of cure. The risk factors for head and neck cancer: tobacco use, alcohol use, HPV infections are the primary ones. Of course, there's those that are sporadic without any cause, but those are the most common ones. The management of head and neck cancers, the mainstay is often surgery. And of course, get through surgery, you have to have good nutrition, good protein, be very functional. But there's also chemotherapy, there's also radiation, immunotherapy, and you have to have good nutrition to get all the way through all those multi-modality treatments. Not uncommon at all to have malnutrition with head and neck patients, even prior. If people are pretty heavy drinkers or smokers, often they're very thin to start with. And so we have to, take that into account. Somebody who's 90 pounds, 100 pounds is not all of a sudden going to be 160 with a few supplements, but it's going to be harder because they have less weight to lose. Unintentional weight loss is very common when people are diagnosed with advanced cancers. And so we have tried to figure out, how do we get ahead of that? Head and neck cancer patients often have trouble opening their jaw. That's called trismus. They may have respiratory issues. They may have digestive issues. Again, aspiration, sores in their mouth, sores in their throat, trouble eating. Food gets stuck when they eat. All of those things are very common with head and neck patients. If they go through treatment, that radiation can make their throat so sore that they don't want to swallow. If people don't swallow through treatment, they're at risk for not being able to swallow after. So very important education to keep them doing that, even if it hurts. Many people can't eat because of the dry mouth or the pain, the sores in their mouth. And then how do we work around that for nutrition? Head and neck cancers have a very high rate of depression. There's research that shows if you put someone with head and neck cancer on an antidepressant, when they're first diagnosed, they have much better outcomes. So depression, they're prone to losing muscle mass and weight loss and being tired. So many factors with head and neck cancer. They often will have airways. If they have a trach, can they eat with a trach? How long has that been in? Do they have a Larry tube that they may be able to eat? So just a whole host of things that affect head and neck cancer patients' nutritional needs. Now, appetite stimulants, often we get referrals for people to talk about appetite stimulants. The challenge with these, there's just not much research out there to show that they help. There's a whole lot of research out there that says they can sure be harmful. So we never want to cause harm. That's the vow we've made. So if there's something that's appropriate that may help with appetite, is there another reason we're using it for? Megace is often used in cancer patients. Again, the research doesn't strongly support that, and there's risk for clotting and adrenal suppression. So you really have to weigh the risks and benefits, of trying any of these. Steroids, for sure, make people hungry for the most part. They often have wanted side effects that we use steroids for. So it can help with bone pain. It helps with appetite. It can help with nausea. It can help with energy. But alternatively, you can only stay on a relatively short period of time where you start getting other side effects, such as muscle weakness. They do cause high white count. They cause hyperglycemia. There can be cataracts. They can affect your bones. So you have to really balance how much of a dose you put someone on, how long they're on it. Are they diabetic, that the hyperglycemia is going to be an issue? If you have them on very high dose for long, you may have to taper it off. So they're good, but you have to use them with caution. Olanzapine is a relatively newer, within the last few years, antipsychotic agent that works fairly well for appetite control. Low dose, 2.5 or 5 milligrams is typically what we use. It works pretty well. It works much better than placebo, as you can see, 43% to 13. It can cause drowsiness, so we give it at night. Typically once a day is a scheduled drug. Give it at nighttime, and it does take a little bit of time to work, but it's pretty low risk, and we do see some benefit from it. Helps with nausea as well as appetite. And so we use it for a combination. We like drugs that do a couple things. The last category I listed is cannabinoids. And again, in Nebraska, they're not legal. So people ask us about those, and we can sometimes talk about anecdotal, but we can't give any recommendations. Again, just not research shown that they're beneficial. It's kind of a mixed research. Some people tell me that it helps with appetite and energy and mood and, kind of whatever they're having, it works. If they take it, we ask that they let us know, but we can't really make recommendations one way or the other on it. Now, there is a drug called Marinol that sometimes we use for appetite stimulation, but again, risk for clotting, we just don't see much benefit in the way of research. So always things with a little bit of caution. Anything natural way of trying to get the food in is always better. Pack those calories with protein and try and sneak that in with whatever you're giving somebody, that protein in there. Protein drinks, those sorts of things, always a much better if you can do it naturally rather than the stimulation. Other things like distraction and small frequent meals, those sorts of things, always a first choice rather than trying another medication. So we look at feedings, type of feedings, obviously oral, and then enteral, which means NG or in the belly. The enteral is preferred. If your gut works, use it, is kind of the thought. Peg tube, J tube, NG, depends on the purpose. Again, are we looking long-term, short-term? Some people that have had gastric bypass can't use a tube just because of what's been done there. The other thing, sometimes if there's carcinomatosis, you may not be able to get a peg tube placed. If there's tumor there, they typically can't place it. So lots of things that have to be looked at there. Parenteral is IV, so TPN. If somebody has a bowel obstruction and they want to try to get treatment to get rid of that obstruction, malignant obstruction, sometimes we'll use TPN, often just at night. But it may help stabilize the weight, but it's not as good typically as enteral. The other challenge with TPN, you have to teach somebody to do it at home. You worry about that sugar, the infection, more expensive, can cause the villi in the intestines to atrophy, meaning they don't work as well. So just higher risk for complications with enteral, but for sure we do use it. Often after a surgery, if somebody's a little bit longer before they can eat, then we think they will bridge that with parenteral or enteral. So again, goals of care, we want to make sure we're helping people, we're helping meet their needs. We don't want to cause harm. If somebody has dementia and we put a tube in, they're likely going to tug it out. So you have to just really work on patients, families, and talk about what that looks like and your reason for considering a certain type of artificial nutrition. If we're going to use that, what does a patient want to do? Are they okay having a certain way of taking diet, nutrition, family, and withholding and withdrawing? So often we'll say, if somebody has high risk for aspiration and they want aggressive treatment, aspiration can be a small thing where you cough like we all do, or it can be significant where they may need BiPAP or they may need a ventilator. Are they willing to accept those risks? If somebody is at end of life and they know they're an aspiration risk, often they'll say, I don't care, I just want to eat. So delineating where they are in their diagnoses, what their goals are, what their life expectancy is. Again, dementia and the terminally ill, we don't recommend artificial nutrition. Perhaps just even for comfort, they may need altered diets. With head and neck cancer patients, they may not have their teeth, and so soft foods or liquids are often what we need to go with. And so part of that is having those conversations, what's important to you? What does your family know? And tying in with that then is advanced care planning. So I've listed a number of documents here that talk about advanced care planning and things we talk with our patients. And sometimes people say, gosh, why are you talking about this with me? I'm not at end of life. And I always say, you don't ever know when you're walking outside what's going to happen to you. It could be a car accident, or you could have something happen that you're not aware of needing these documents until it's too late. If you have surgery and need a decision maker, then it's too late if you're not able to have that conversation because you're under anesthesia. So we recommend for all of our patients, have a power of attorney for healthcare. Who's your first decision maker? Who's your second? That only comes into play if that patient cannot make their own decisions. But it's great to have a backup because we as a healthcare team want to know who they trust, who they've had conversations with. Just because someone's a spouse, they may not be the right decision maker if they can't make those hard decisions that the patient wants. If somebody has children, adult children, they may be the second surrogate decision makers, but perhaps the family is estranged, So we need to make sure that we're talking to the right people and making that person who the patient knows will make the same decision as them, their decision maker. Financial power of attorney, they can go to banks to get this done, but it helps. Just say, if I can't pay my bill, if I can't get to a bank account, who can do that for me? Same idea, but just financial. You can have different people on these documents. They don't have to be the same person name. Durable power of attorney is just more of an overall umbrella. It includes bigger like medical, financial, sometimes some other things. Living well might be part of that, but it includes that. So however someone wants set up, the durable power of attorney is usually done more through an attorney. The living will, people will say, gosh, I want to do a living will. You might have heard like 5 wishes. Those were okay. They're more general. I like about them is they get people thinking about what decisions might I have to make, but they don't give me the exact information. So even if somebody has a living will, I still want to talk to them more specific about what they would or wouldn't accept. The last will is their document after they die. So living will is decisions for end of life. The will is how do I get rid of my estate, my belongings? And so the last thing I want to talk about is what we call the post form, physician order for life-sustaining treatment. I use this an awful lot with people. I like it because it gets down to the nitty-gritty, and I can have a good conversation with somebody about, do you accept CPR? What does that look like? Do you accept intubation? What does that look like? What does short-term intubation look like? What is long-term? What about a trach? What about living on a vent? What does that mean for feeding? If they have a vent, they're going to be either on IV or enteral. If they get a trach, they're going to have a peg tube. So just thinking, gosh, I'll take a trach and I'll be able to do what I do doesn't match. Sometimes if they say I can't eat, well, then I don't want that. So really important on that part. But the pulse tells me, what do they accept for CPR? What about breathing treatments? Do they want to be in the ICU? Generally, do they want to try and avoid surgeries? Those sorts of things. And we fill that out. And then it also lists on the back who their emergency contacts are, the power of attorney. And once that document is filled out, then they sign it, or their surrogate if they can't. We would sign it as a provider. And then it goes on their medical record here, but they also get to take it home. So if something were to happen at home, then they call 911. The EMS will look for this document on their fridge and say, gosh, you know what? You have a DNR, a DNI order, meaning don't do those things. And then they don't have to. They would just transport him to the hospital. So there again, healthcare, it saves a lot of things the patient doesn't have to go through. Also saves a lot of services and healthcare that we may want otherwise to do to patients that they really don't want. So advanced care planning can include nutrition. Some of those documents will say, do you accept, and the post does, do you accept a feeding tube? Do you accept enteral? Do you accept other types of surgically placed tubes. So it's on there because you can't take it just by itself. It has to be their whole picture. What are their decisions and what does that look like? Now, nutrition is not as urgent of a decision as, say, CPR or breathing tube. So sometimes we have good discussions about feeding, artificial feeding, but we may just mark on the phone. It was discussed, but not decision made because there's so many different scenarios where you might need artificial feeding. Impossible to know at the time, but I want to make sure people have an understanding of what that means. So advanced care planning definitely still fits in with nutrition. And so in conclusion, nutrition plays a vital role in patients with, well-being before we have illness, as they have illness, mental health, just interactions with others, managing symptoms, getting them through treatment is so, so important to make sure that nutrition is part of our discussion. If their taste changes with chemo, how do we get by that? How can we pull the dietitians in to help with adjusting things so they can eat and enjoy eating? Are there nutritional supplements that they can recommend that are better for them or not? If there's trouble with paying for those, dietitians can send me a script and then I sign that, it goes to the pharmacy, and often we can have insurance help pay for some of those. So lots of different ways if someone can't. If they have food insecurity, social worker is fabulous with helping them with, vouchers for Hy-Vee or where are the food banks. A number of people have food insecurity. So lots of different things we have to look at with nutrition on our patients. It's costly to have cancer. And so they sometimes don't buy the best produce or the best products that may be better for them because they have to limit what they can do. There's limitations though based on their conditions. So if they have dementia or end of life, we're going to have a very different conversation than if we have somebody who's just starting out on cancer treatment. What does a patient want? How advanced are their illness? Lots of different things. Do they have challenges that they can't eat normally? Do we have to work around some of the surgical things that they've been through or the radiation effects that they've been through? So all very important to see where they are in their treatment, what they've been through, and how does that affect nutrition and eating. And so healthcare providers, including palliative care, really need to look at that person as a whole, not just what are you eating and how do we get you to eat more. There's likely more playing into it. Is there, spiritual, is there emotional needs? Is there family things? Is there cultural things with certain foods they usually like? Have those discussions before they have a procedure like a peg tube. Talk about them before they have it and say, is this really the right thing for you? Here's what it means. Before they have a trach, before they have a laryngectomy, what does that mean for eating and what does that mean for diet? So those sorts of things are really important to talk about before patients have a treatment that they agree to. Really important. But we definitely rely on our dietitians to help with things that we need their expertise in. But palliative care is happy to help and happy to have those conversations. And so I'm going to turn it over to the dietitian. And if you have questions, please feel free to reach out to me. I'm on email. You can call our office at 2917, and we're happy to help in any way we can. Thank you.
I do appreciate Kim giving us all that information. I'm Gina. I'm one of the dietitians over at the Cancer Center, and I work with Kim quite a bit with a lot of these patients over here. So our learning objectives for my portion is, what is the dietitian's role in the palliative care team? I'm going to talk about nutrition support and when is that indicated in palliative care, and then help you all to develop a general understanding of our assessment, what we do with the patient, and then nutrition goals of the palliative care patient. So biggest part we're going to do is we're going to do a nutrition assessment. This is to see the risk of the patient. We're going to determine the severity of malnutrition, if there is any malnutrition. And we want to work with the patient and the family and the care team to establish interventions to address any nutrition concerns or malnutrition. Oftentimes there's a lot of nutrition and quality of life issues that come up. So usually the family is very involved at the point when the patient comes to palliative care, a lot of patients may actually feel pressured to eat or to accept a certain nutrition intervention because of their family members. And then also, we get a lot of questions about nutrition that is maybe not a correct view. So we do have to help walk patients or family members through some of those things that aren't necessarily true, usually revolving around enteral nutrition or nutrition support of some kind. So, and Kim kind of touched on this, is to recognize that palliative care does not mean hospice care. So, a patient can be receiving palliative care, meaning their cancer treatment is curative intent. They are fully committed to the process, and their nutrition interventions can be as aggressive or not aggressive as they want them to be. It's all about the patient's preferences, how they want to be comfortable, and their quality of life when we talk about these things. So some of the things that we work with these patients would be managing treatment side effects, whether they're on chemo or radiation or both. There's a lot of side effects that impair nutrition. We work with constipation or diarrhea, so bowel issues. Oftentimes early satiety, meaning patients feel really full very quickly, poor appetite, wound healing. The patient may have a wound because of surgery or poor nutrition in general. We work with nutrition support, of course. We work, dry mouth, sore mouth, taste change, nausea, vomiting. The biggest thing I talk to patients about too is an eating schedule that's consistent and supportive of their medication routine. And I can talk a little bit more about that when we get to pain and nutrition. But I'm surprised at how many patients will take heavy medications like narcotics on an empty stomach and wonder why they're nauseous all day long, or they're having a lot of pain and they have these medications on board. So how can we get them to take their pain meds and then ensure that they eat about 20 minutes after taking the pain medication so that they can get the most out of that medication, and then they can go to sleep. So a lot of the medications that they're on make them really drowsy, and then they end up sleeping all day long. So it's a lot of talking to the caregivers more so about how medication and eating schedule works, and of course appropriate food choices for their needs. Okay, so pain in the human body. Kim did a good job of touching on this too, and we're glad for Palliative to be on board when it comes to this, because pain, if you've ever had pain, it affects our perception of our appetite and of our hunger levels. It just sucks us of any energy we have. So medication management of pain with narcotics can impair appetite, increase fatigue, cause nausea or vomiting, and constipation. So a lot of these drugs are very constipating, and that affects a person's ability to have an appetite or to take in food at all. So that's another big component that we work with these patients on, is keeping them from getting constipated. And Kim did touch on cannabis, or the use of medical marijuana. This is illegal in Nebraska, in the state of Nebraska. There's currently no laws or policies for medical marijuana in this state. It did not actually make it very far in legislation. So this is actually a discussion that I get with patients and family members. A lot of patients ask me more so when they're on chemo, and they may be receiving palliative care as well, but if they can use marijuana, if they can take an edible, that sort of thing. Like Kim said, there's not a lot of strong evidence for one way or another using, not using these. I think it's more anecdotal. So some patients may report relief with this type of intervention and others don't. I what I tell patients when this comes up is one, to talk to their medical oncologist or their palliative care provider, any physician that is prescribing chemotherapy or a narcotic type medication. I encourage them to have that conversation with that provider. But I also, have the honest conversation. If you are comfortable with using marijuana or you've used it in the past and you know how you react and you want to try it, that is your that's your decision. That's the patient's choice. Um, so that's kind of where I leave it. I leave it up to them. Now, medical marijuana is legal in Iowa. It's called the Medical Cannabidiol Act, and there are very strict regulations on the prescribing provider, the patient, and the manufacturer. So it's very strictly controlled in Iowa, but some patients may choose to get treatment in Iowa for that reason. Jumping back a little bit, nutrition assessment. So us dietitians will come in, we'll look at the patient and try to determine, is there any sort of malnutrition in this patient? Are they coming to us with a new diagnosis already at a disadvantage? And then we define the severity based on a lot of factors like how much weight have they lost over what period of time, how many calories are they eating in a day, um, we do a nutrition focused physical exam. So what kind of physical attributes does this patient have? Do we see or feel muscle wasting? Do we see, edema or fluid accumulation? And malnutrition can occur in the acute illness setting, or it can be present in the chronic illness. And the criterias are just a little bit different based off time and severity of weight loss. Uh, so all cancer centers do require a screening tool that would prompt like a dietitian consult. And we have that here at Estabrook, called the psychosocial distress tool. And inpatient uses the MST tool. I'll talk about that a little bit later. But we can always, you can ask your patients questions no matter if you're a provider, what part of the care team you are. If you're having an interaction with your patient where they're mentioning I keep losing weight and I don't know why, or I have no appetite, or I have a really hard time chewing my food with these dentures or my teeth. Those are all, those should be light bulb moments for any care team member to say, we have dietitians. Do you want to talk to a dietitian? And so I encourage all of you as providers to to prompt that conversation with your patients if you think it's a concern, to get them the right resources for nutrition. Okay, so the two terms that come around a lot, sarcopenia and cachexia, they both can be present at any BMI, and they're both have to do with muscle loss, not necessarily fat loss. So I'll start with sarcopenia, which is a severe muscle loss. Usually, we pick it up when we do that nutrition focused physical exam. There's lots of places on our bodies where we can see that a person has lost muscle. And then, you know, we know this is influenced by age, other comorbidities, so a cancer diagnosis, malnutrition, weight loss over a period of time, their patient's level of physical activity, treatments, medications. Then we have cachexia, which is a bigger picture. We're looking at things where inflammation is is indicated, labs in our body, and we look at the muscle loss assessment as well. So with cachexia, there's a lot of the quality of life is starting to be affected, meaning the person is maybe not able to do as much as they used to be able to do, and they're having all of these kind of comorbidities or issues come about. And like Kim said, this is very challenging to reverse once a person gets to a level of cachexia. Even nutrition support can't really get that back, get their muscle, get their full function and quality of life back for them. Very common in gastric cancers, pancreatic cancers, esophageal, head and neck, lung, colorectal, and prostate cancers. So this is a long slide. I apologize. I'm going to just kind of skim through it here and sum it up. So in the palliative care patient, indications for nutrition support, they're receiving curative intent therapy for their disease, meaning they're getting treatment. The idea is that it's going to cure the cancer and they're going to be able to recover and go on with their life. They have a dysfunctional GI tract, or they're not able to take in oral nutrition for whatever reason. And that starvation would precede the death from the disease. So that's an important one. If the person is going to starve prior to the disease taking over their body, then we need to look at other interventions like nutrition support. And then if for any reason the treatment of their disease would be interrupted from malnutrition. Influences for choosing nutrition support would be the prognosis of the disease, the patient's functional status, and the desired quality of life. Like Kim said as well, there's a lot of studies out there. They all have different outcomes, different results, and this is an area of research that we need to continue to study, to look at. So artificial nutrition, parenteral nutrition, meaning that IV nutrition, this is generally reserved for very GI impaired patients. A lot of our female gynecological cancers require some sort of parenteral nutrition along the way. And this can increase your lifespan by about 4 weeks. So for patients with advanced cancers, if they're able to go home on parenteral nutrition, if that was the indicated type of nutrition support, and they are able to receive that at home, which you can, this has shown to improve overall quality of life. There's a decrease to the amount of weight they lose. They're not having all these GI symptoms. Their mental status is improved, energy level, activity, all of that. But outcomes of parenteral nutrition are quite opposite if a person remains inpatient. We don't ever want a patient to be in the hospital on parenteral nutrition for a long period of time. That is just generally never needed. And Kim mentioned some of those reasons why. It's invasive. There's risk for fluid overload, infection, prolonging life when the quality is just not there. So, and then we have enteral nutrition, which is, your GI system is still working. So we're going to place a tube somewhere. And overall, this is perceived as beneficial during treatment. Anytime you have someone with a feeding tube, receiving enteral nutrition for a long period of time, the quality of life gets diminished. This is not what we're trying to go for with a feeding tube situation. So again, you have a palliative patient, they're receiving some level of cancer therapy, and the indication for enteral nutrition would be if their starvation would perceive their death by disease, um, or they're not going to be able to make it through their recommended therapies without getting some nutrition support. So, again, there's not a lot of conclusive evidence on enteral nutrition support long term here, but and then artificial hydration, so fluids, IV fluids. This is essential for on treatment patients. Dehydration can be very, very hard, very detrimental on patients receiving any sort of therapy, specifically chemotherapy. And if not on treatment, that the option to do IV fluids is up to the patient and the provider. In some situations, hydration can exacerbate the disease condition. So it's really about patient preference, and that we don't want to cause any sort of discomfort. So sometimes in a palliative setting, like Kim mentioned, if we know that they're aspirating or their disease prognosis is advanced, then maybe that person just wants to be allowed to do ice chips or take a few drinks of something that they want to drink and risk aspirating versus having to go in somewhere and get fluids, or having someone come into their home and give them fluids. So, nutrition support and end of life. This is a transition from palliative to hospice. Stopping nutrition and allowing the body to transition into a negative energy balance. And dehydration is actually protective at reducing suffering at end of life. So I've listened to a lot of different things about this idea, and our body is very smart at doing this. And so if we give it a chance to let it, the starvation is almost like a natural anesthetic, or it gives us a feeling of euphoria. It's the body's process that is protecting us at the end of life. So we really do have to consider when it's appropriate to not use nutrition support, and let that person's body do the work at the end there. So, nutrition goals of care. I know we're getting close on time here. So, the goals should align with the cancer therapy. So, how aggressive is this person being treated, and are we helping them from a nutrition perspective that's going to allow them to meet those treatment goals, get through treatment? If surgery is the goal or the primary treatment, malnutrition has to be addressed for the best outcome. When it comes to surgery, you have to look at the nutrition, and if they come in pre-surgery at a certain level of malnutrition, you can intervene with some nutrition support about 2 weeks ahead of time. Can be enough to get that person back to where they need before surgery. Defining the patient's nutrition care plan. So is the family supportive? Is the patient supportive? Is the provider, the care team on board? And then can we address the current level of malnutrition? Can we address the cachexia or the sarcopenia? Can all those things be approached along the way? And this was the last piece that I was going to cover. This is the what we're doing in the hospital for malnutrition. And if you have more questions about that, I can chat. You can ask. But this is a good example of how we're addressing malnutrition on the inpatient side, and probably a lot of our palliative patients fall under this. It's an example of nursing, working with provider, working with dietitian to really treat this patient. And
Gina, do you have any strategies for families? Because I think that is kind of the hardest part when it comes to, especially end of life or palliative situations, because families are, I mean, that food is something they can do. And sometimes I think they push food when it's probably not warranted.
yeah, so this is that going back to addressing myths is generally with the family members. And I just give them facts like what I just gave you guys. So, I kind of talk to them about, well, we know this about your loved one's disease. This is where they're at, or this is prognosis. This is their goal of what they're trying to do in their treatment right now. And either this is indicated or this is not. Um, and I talk, depending on what level, what they're asking, should we do a feeding tube? Should we not? Generally, I'm always going to sway families against a feeding tube in palliative or close to end of life settings. And like reassure them that, the body is eating food by mouth is not generally on the forefront of someone's mind right now, on the patient's mind.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.